Thank you, Shirley, for your time. She's a clinical psychologist and an associate professor of psychology at Beth Deaconess Medical Center, Harvard Medical School. Her research focuses on adolescent and young adult suicide risk, self-injury, and mood disorders, with a particular emphasis on identifying early predictors and prevention strategies. She has led several large-scale longitudinal studies as well as interventional studies. Dr. Yen's work is instrumental in shaping evidence-based interventions for high-risk youth and improving mental health outcomes during critical developmental periods. She's very impressive, and what caught my eye is she's been continuously funded for the last 25 years by National Institute of Health, and that is impressive. Shirley, please take it away.
Thank you so much for that introduction, and thank you especially for inviting me to be part of this really impressive conference and on such an esteemed panel, and I'll look forward to further discussion later. So, well, despite the positivity of my title, I will be starting off with some rather depressing statements, which is that currently we are facing multiple crises of despair, especially in the United States. And this is a chart of suicide rates in the US. And as you can see, suicide deaths have been increasing for every age group except for adults over the age of 65. And I know that we have some youth participants as well, which is great to see. In youth, it's a leading cause of death among all racial and ethnic groups. And it is the leading cause of death in Asian and Pacific Islander youth, as well as Native American youth. And across all groups, the number of youth who've died by suicide is now greater than the number who've died in motor vehicle accidents. Also notably disturbing, but not the point of my talk, is that the fact that homicide is the leading cause of death in Black youth. So, you know, one of the amazing things is that over the past several decades, we've made numerous advances in treatments, in psychopharmacology, witness the widespread availability of SSRIs, as well as neurobiological interventions like deep brain stimulation, and also evidence-based psychosocial interventions like cognitive behavior therapy and dialectic behavior therapy. Yet we have not been able to reduce the rates of suicidal behaviors. And I think that there are several reasons for this. First is that most at-risk people are not in treatment. Now, this is not necessarily drawn to scale, and it represents all suicide deaths across all ages, but it's meant to highlight the large proportion of individuals who are at risk for suicide but not seeking treatment. It's estimated about 79% of suicide deaths are those who die on the first attempt. And only 22% were in treatment at the time of the suicide. Let that sink in. About 79% died on the first attempt, and about 22% were in treatment. Okay? Now, the overlap in middle, around 7%, that represents those who use some emergency services, like an emergency department, which may or may not have been voluntary. So clearly, we need interventions that are outside of traditional mental health and are both acceptable and accessible for a broader range of the population. So now I suspect that another reason why we've been less successful in reversing the trend of suicide deaths is that we've been over-focused on one pathway, which I refer to as the risk pathway. Now, most interventions for suicidal behavior have focused on this pathway, which either focuses on treating distal risk factors such as depression or substance use, or symptoms of those, or proximal risk factors, such as teaching emotion regulation skills or distress tolerance skills, to manage the very strong emotions that stem from stressful events. Now, this is quite warranted, and I support a lot of this work because risk factors are salient drivers of suicidal crisis, so it is very important. But there's another pathway, and there's an equipoise between risk and resilience. So even the highest risk individuals are at high risk, are not at high risk all the time. In fact, most times when at-risk individuals are faced with a stressful circumstance, they do choose alternative behaviors. In fact, we are all practicing resilience every single day, right? So how can we strengthen the resiliency pathway to withstand the very strong forces of the risk pathway? So I actually have come to this work from the empirical scientific direction rather than the spiritual direction, and it's great to be at this conference to see a convergence. But how I first became interested in positive affect in relation to suicidal behaviors was a research study I conducted that followed teens who were admitted to an inpatient unit, psychiatric unit, due to some suicidal behavior. And we wanted to examine what factors predict future suicidal behavior in the 6 months following discharge. And that's a really high-risk time for recurrent behaviors. And to my surprise, low positive affect was a really robust predictor, so that those who endorsed lower trait positive affect at baseline were significantly more likely to have more suicide events, which we defined as either a suicide attempt or an emergency intervention to intervene, such as an ER admission or inpatient admission during the 6 months of post-discharge. And this finding held up even after controlling for a lot of important and significant variables like depression severity, anhedonia, and since I found this, a lot of my colleagues have replicated something similar. So I became interested in some positive psychology interventions, and around this same time, there was an explosion of stories about positive psychologies in the media. But predictably, there have been some backlash to that. And that continues today in what people refer to as toxic positivity. I especially like the title of the middle one, Happiness, Enough Already. And that refers to the pressure to maintain a positive mindset no matter how bad the circumstances are, which can feel invalidating to some people or dismissive or sometimes just downright annoying. And so clearly we need to rethink our approach to positive psychology. So I turned to research from affective science. I'm a psychologist, a clinical psychologist, and I identify 3 core principles. The first of which is the negativity bias. Now, most everyone is familiar with the function of negative emotions, which is to protect us. It's to enhance our survival. Now, fear and anxiety tells us there's a potential danger in our environment. Sadness tells us there's a potential loss. And anger tells us that someone might be threatening or wanting to harm us. And then when we experience one of these emotions, we tend to narrow our attention on the perceived threat. Now, and when we do that, we narrow our attention, we also discount any positive or competing stimuli, right? This is evolutionarily adaptive. And we're wired to do this because once upon a time, if you're being chased by a saber-toothed tiger, being distracted by the pretty flowers you're running past, that could be dangerous, right? So it's evolutionary adaptive. Focus on the threat, discount other things. But positive emotions also has a very important function. And according to Barbara Fredrickson's Broaden Build theory, positive emotions may serve to do the opposite, which is to broaden your attentional scope. Now, social psychologists have actually been building evidence for this theory using experimental paradigms, where they found that when you increase positive affect through a mood induction, like in a laboratory, show clips of puppies playing or other happy images, and then you do an experimental paradigm, that those who are given the positive mood induction, that translates into more creativity, better problem solving, more trust in strangers. Those people rated their close, intimate relationships as being better, okay? So you might recognize some of these as also protective factors against suicidal behavior. And then the third theory that I relied on is sort of the positivity ratio, that to overcome the potency of negative affect, that we need to have a higher ratio of positive affect. And this concept has been popularized by relationship researcher Dr. John Gottman and his colleagues, who they observed thousands of hours of videotaped interactions from numerous couples, and they found the balance of positive interactions to negative interactions was a really important factor in couple satisfactions. Now, Gottman uses this analogy of an emotional bank account in which positive interactions are like small, consistent deposits, whereas negative interactions are like big withdrawals. Now, it's important to note there's a broad array of what constitutes negative interactions that can range from minor irritations or annoyances to big abusive circumstances or unsafe circumstances that shouldn't be tolerated, no matter how many positive interactions there are. But here's the interesting thing about the positive interactions, is that they are usually very small acts or gestures, and they have the same deposit values as big grand gestures. So think about this in your own life, that sometimes it is the unexpected small gestures that really fills your heart, right? Those have relatively the same value as the big gestures. So if we were to apply this to the individual, what that suggests is that, well, aside from trying to reduce stressful conditions or circumstances or targeting negative emotions, we should try to intentionally increase the positives to counterbalance the negatives. So in rethinking positive psychology interventions, I first think it's important to distinguish the risk and resilience pathways that I presented on earlier. A framework that's widely used in the context of reducing risk, and it's been referred to before, is cognitive behavior therapy. In CBT, the focus of the intervention is typically on thoughts. That by challenging our maladaptive cognitions, this should result in changes to behaviors and emotions. And in many cases, it does. Sometimes we target the behavior, which is called behavioral activation. This model makes a lot of sense when thinking about the protective effects of negative emotions, which would be hard to target directly, right? They're meant to protect us. But when we're thinking about the context resilience building and positive psychology, focusing our intervention on thoughts, for example, optimism or positive thinking, it might be reassuring, or it might be invalidating of someone's actual experiences. And sometimes it may be, there may be a cost to overconfidence if it's not matched to realities. So it's important to build, accurate expectancies. Now, I can hear some skeptics saying, well, what about thinking about something, visualizing and having it manifest? Or, isn't there are a lot of data saying that optimistic, confident people just do so much better? And the answer is yes, that is all true. It's great if you can be optimistic, if it can be internally generated. I'm a clinical psychologist. I design interventions. I would caution it as a therapeutic approach. Instead, I would argue that when we think about building resilience and the functions of positive emotions, we might want to flip the CBT triad to prioritize emotions as our primary targets. Because based on the affective theories, this is evolutionarily adaptive, and this should be an amenable target. But how can we target emotions without invalidating someone's emotional experience? And I think the answer lies in something very simple, often overlooked and not practiced enough, and addressed in our earlier presentation by Swami, which is attention. This is a quote from the father of American psychology, William James. "My experience is what I agree to attend to." Attention is a gateway to all of our experiences and our consciousness. And it is the first step of any emotion regulation strategy. Attention is arguably the most powerful resource we have that we all have access to. And social media companies know this, and they are vying for your attention, okay? It is a very valuable resource. So with all this in mind, I developed the skills to enhance positivity intervention. I actually prefer the word exercise to skills because exercise suggests that it's something to be done on an ongoing basis, that it should be something that's habitual. But all the E's and P's did not make a good acronym, and many of you know the key to successful NIH funding is having a good acronym. So STEP it is. So STEP is acceptance-based. We're not trying to change the negative into the positive, but we're trying to build small moments of attention shifting. It's adjunctive. Per the model I showed earlier, many people need individual therapy where they can focus on the risk pathway. I'm not trying to replace individual therapy. And it's emotion-focused. We focus on the eudaimonic versus the hedonic that Dr. Keshavan was talking about. The eudaimonic is more affiliative. It's more purposeful, sustaining. Whereas hedonic, which is akin to pleasant events, one can easily get on the hedonic treadmill. Pleasant events or distractions can be important emotion regulation tools. But instead, we're trying to encourage exercises that lead to greater connection with others and are more likely to be generative of more positive emotions. And finally, it's practice-based. We supplement our individual sessions with automated text reminders for mood monitoring and exercise practice. Practices are often small steps that are very feasible and can be practiced daily. So it's the mental version of muscle memory to practice these small moments of attention shifting. So here are the main components of we have 4 in-person sessions. The first is focused on rapport building and psychoeducation, and that covers many of the functional aspects of negative and positive emotions I talked about. Psychoeducation gets at the why. Why am I doing this? Now, this is particularly important, since, especially a lot of my trials are with teens. Teens need an understanding of why. Why are you asking me to do this? Okay, and it's also important for those who might have a hard time allowing themselves to sit with positive emotions. A lot of people who are depressed feel like they don't deserve to feel happy. And those are very hard questions to get at. And sometimes we have to sort of give them some external permission structure to say that, we've evolved this way. And it's important to also focus on the positive things that you're discounting. And as it turns out, based on our data, psychoeducation was surprisingly well liked by the adolescents and young adults. We selected 3 practices that are familiar to most of you. I'm not going to go over mindfulness, meditation, gratitude, and savoring. But I will mention that we presented multiple ways of practicing to help teens identify what works best for them. This is essential because many people, especially teens, might have an initial reaction of, I tried that mindfulness stuff, it doesn't work. Well, that might be because they tried it in their PE class with 30 other kids in the room, right? And so what we do is we try to personalize a practice so that it's feasible for that individual. Some prefer concentrative mindfulness, focusing on their breath. Some teens say, I have a hard time sitting, so we try to do some movement or stretches. Others might want to focus on a word. So we try different ways. And the same with, the key is feasible practice. And then we do this similarly with gratitude and savoring practices. We present multiple ways. Some can be introspective, that you reflect on. Some can be interpersonal. We suggest the interpersonal ones because that has an added benefit of strengthening bonds. I'm going to have you do a quick practice right now. For those of you, if you have your phones available, I would actually invite you to take out your phones, go to your photo app, and just pick a random photo. And I would like for you to just reflect on the moment that you took that photo. Why did you take that photo? Was it a moment of awe or natural beauty? Or was it a moment of affiliation that you wanted to capture? Or was it pure amusement? And as I do this exercise, I love doing this in groups because what I often see is people smiling, or sometimes people laughing, chuckling a little, or showing their, the person next to them what they took. Okay? So this is just a simple practice that kind of brings you back to that moment, because savoring is sort of putting the pause button on something that we wanted to capture. So after the 4 in-person sessions, the intervention switches to daily text messages for a month and then every other day for 2 months. Now, the main components are a series of 6 mood monitoring prompts with some questions about positive moods and some about negative moods. I'm just showing you an example. This is not the full program. They then receive a message based on an algorithm of their positive to negative mood responses, and then we'd ask them to select a skill to practice. Would you like to practice mindfulness, savoring, or gratitude today? And based on the response, we send them a practice reminder from our bank of messages. So this is all automated. So for example, if they select savoring, they may be instructed to recall something they found funny during the day and share it with another person to build connection. Now, if they don't respond to any of the initial prompts within an hour, they would still get the last message to ensure that every day they receive a practice reminder. So I'm going to talk a little bit about our results. So we've completed multiple pilot trials of STEP. We're currently in a larger, big multi-site study right now. Our primary target was to reduce suicide events. And what I mean by events are either a suicide attempt or an emergency intervention to intercede an attempt, such as going to the ER or inpatient. Now, the graphs here depict both attempts on the left, the shorter bars, and events on the right, which is inclusive of attempts. Now, in our prior naturalistic study, where we just followed teens after discharge, which is the light blue bars, we just followed them, they had no other treatment. About 18% of teens, or actually they had treatment as usual, which is whatever treatment they were going to get in their environment, but we didn't give them a treatment. About 18% of teens made another attempt, and 36 had a suicide event over 6 months. That is remarkably close to what we observed in our control group, or our placebo group. We call it enhanced treatment as usual, where we sent them, instead of the STEP messages, we sent them healthy habits messages every day. So the dark blue and the light blue are pretty similar, okay? But in both of our adolescent STEP groups, which is the yellow and the purple, we see fewer attempts and fewer events. And then when we did the RCT, which is the darker colors, the dark blue and the purple, which is where teens were randomized and were able to do a direct head-to-head comparison over 6 months of follow-up. And I should mention that this was a pilot trial, so it was 52 that were randomized. So we found that over 6 months of follow-up, 19% of those assigned to STEP, which is a purple, had a suicide event, compared to 38%, which is a dark blue, in the enhanced treatment as usual, where they just got the healthy habits text. Now, as some participants had multiple events, we also wanted to look at the total number of suicide events. 6 suicide events were reported in the STEP participants and 13 in the enhanced treatment as usual. So those randomized to the STEP intervention have 50% fewer events and 50% fewer participants engaging in suicide events. So this is a medium effect size. Now, while we've had slightly fewer participants reporting attempts, there were no differences in the number of suicide attempts. So this suggests that most of our effect was actually attributed to the lower frequency of emergency help seeking in the STEP participants. I still think that's a very important outcome. not only because EDs are overstrained, but it suggests that the teens who are feeling, in crisis, they actually felt a greater sense of agency and self-efficacy in being able to navigate their own emotional distress. And I think that's a really important finding, right? That can be generative. And then when we look at suicide ideation, here we have percent with active suicide ideation the week prior to baseline, prior to their admission on the left, and then the percent with active suicide ideation on the right set of bars. And what I mean by active is that they had a plan or intent, that it's not just passive thoughts. And the right represents the worst week of follow-up. And we see a much larger decrease in the proportion of participants who reported active SI in the STEP condition compared to the enhanced treatment as usual. So we also did a version of STEP as a group intervention with young adults in outpatient treatment. So these were not inpatient teens. The good news is that both groups, they were already in treatment for depression, but both groups made significant improvements in depression, but there was a significant improvement in suicide ideation and positive affect in the STEP group only. Now, our goal in the intervention was actually to increase attention to positive emotions and experiences. We did find that on a dot probe task, where people are presented with happy versus neutral stimuli, and then they have to respond to a probe, that there was a significant difference in the reaction time, where those in the STEP condition responded much more quickly to positive words at follow-up compared to enhanced treatment as usual. And then in our young adult group, we used a different implicit task called the IPANAT, and we found that implicit positive affect increased in the STEP condition and decreased in the treatment as usual condition. So the exciting thing here is that we've been able to find significant effects in our treatment, both across multiple units of analysis, including observable events such as suicide events and hospitalizations, as well as self-report in reduced suicide ideation, as well as implicit tasks in terms of greater attention to positive stimuli. So, quick poll, which type of practice do you think was most frequently requested by teens? Who thinks mindfulness? Show of hands. All right. Who thinks gratitude? Who thinks savoring? I love this. So the answer was actually mindfulness. You all answer savoring because I primed you. So the exercise was effective. And I also saw a lot of people say gratitude. The research for gratitude is so powerful, but you know what? Teens don't like gratitude as much. So there's some developmental effects here, potentially. So in summary, we had really good preliminary data in these pilot trials, and we're currently testing STEP in the multi-site study for which we've completed recruitment on 200 teens. We're also applying STEP to different populations and context. In thinking about the possible mechanisms, obviously we were targeting increased positive affect. That was our primary mechanism. But it doesn't stop there, because our whole entire premise, and the premise of the Brodmann Bill theory, is that positive affect then leads to all sorts of other benefits. And I'm just going to quickly highlight three here. First is, attention. That the microbursts of practice that we had may help gain greater control over attention, which is the gateway to all of our experiences. And then our practice, our ability to have them choose exercises enhances agency, and our gratitude and savoring exercises have interpersonal aspects, and mindfulness increases in a connection to everything. And it's this connection and sense of belonging that is so foundational to the drive to survive. And I am grateful to you for your attention. Thank you for your time and attention.